Good afternoon, everybody. I'm introducing Ally Dudman, my Butler University PharmD student. She is the fifth in our series of Bring Lunch and Learns, her category, sleep disorders and night terrors. It's all you.
Thanks for the introduction, Dennis.
Okay.
So for the objectives today, I want to go through the differences between REM and NREM sleep. These are just sleep stages. I'll get through that a little bit in more detail soon. And then I also want to distinguish between nightmares and night terrors. So there are over 100 sleep disorders, so that was a lot for me to choose from when I picked this topic. However, they did have 6 categories, so insomnia, parasomnias, hypersomnia, breathing-related circadian rhythm, and movement disorders. So parasomnias are a catchphrase. It's like a big bucket of all these abnormal sleep behaviors. So you can get sleep talking, sleepwalking, night terrors, nightmares, and even more than that. So I wanted to look at the link between sleep and mental illness, because sleep complaints are frequent among psychiatric patients. They're in a lot of official diagnostic criteria for many of our patients. Looking at one article written by American Journal of Psychiatry, out of 100 patients, 80 had insomnia, and then 72 had insomnia, and 80 had sleep disorders. And then overall, looking at the U.S. population, 1 in 5 Americans have some sort of chronic sleep disorder. 4 out of 5 Americans with mental health issues have an accompanying sleep issue. So it's a significant portion of our population. So this graph just shows you the sleep duration across mental health disorders, and then to the right you'll see the healthy group. So usually it's about 7.3 hours, around there is the average amount for women, and then 7.27 for men. The lowest for men was eating disorders. However, eating disorders are more common in women. But overall, the lowest was PTSD, which makes sense. But as you can see, they're all lower than the healthy group. So REM versus non-REM. REM stands for rapid eye movement. Your eyes will move during your sleep in rapid directions. This is just one stage. And then NREM, which is non-rapid eye movement. This consists of 3 stages. REM is important for dreaming, memory, healthy brain functioning. And then NREM is important for bone, muscle repair, repairing tissues, and strengthening your immune system. REM, so all stages of sleep, you'll go through a couple cycles a night. REM will get longer as the night goes on, and then NREM will get shorter as the night goes on. So here's a graph just to see how the cycles go through your night. You'll get typically 3 to 5 cycles a night is the goal. And then NREM, it's basically light sleep to deep sleep, so you'll go through that transition. REM is where the dreaming occurs, but it's in your lightest stage of sleep. Moving on to insomnia. So this is the most common disorder among sleep disorder overall. So I was looking at the criteria of what classifies as insomnia. So usually you'll have one or more of the following symptoms. You'll have difficult getting to sleep, maintaining your sleep, or you'll have early morning awakenings where you can't return to sleep. This causes a significant impairment on some of your daily life activities through social or education or your job. It'll occur 3 nights per week, and it would be present for at least 3 months. So 1 in 7 adults have insomnia in the U.S. It's more common in women and people over the age of 60. And then cognitive behavioral therapy is first line as treatment. This consists of sleep hygiene, and I'll get further into detail on that soon. And then common meds you can use, sleep onset and sleep maintenance. So to get to sleep quicker, you can use zilophone, Ramelton, temazepam, triazolam, Zaloplan, and zolpidem. For sleep maintenance, doxepin, zolcapone, temazepam, torexerant, and zolpidem. I bolded the ones that are in both categories. So cognitive behavioral therapy, CBT. This is just a form of talk therapy. It helps identify thoughts and behavior that lead to sleep problems, and their idea is just to replace them with good habits. So that can include good sleep hygiene habits. So that can be not using your electronics 2 hours before bed, only using your bed for a place of sleep, not watching TV in bed, kind of like that thing. And then relaxation training. So you can do meditation before bed. You can use biofeedback devices, so monitoring your heart rate before you go to bed and keeping a diary, just to identify patterns to help promote sleep, good sleep. So some clinical pearls of sleep onset meds. Escofixone, it has a bitter or metallic taste. Ramelton, it has no abuse potential, so you can use it for long term, and then you should avoid that in severe liver issues. Temazepam and triazolam have less daytime sedation because they are shorter acting throughout the body. And then Zalopone has, if you take high fat meals, it can delay the absorption of the drug. And then zolpidem, you should use lower doses in females. And then going on to sleep maintenance, the ones in blue are the ones that are different. So doxepin is the only antidepressant with FDA approval for insomnia. And then torexerant is contraindication in patients with narcolepsy. Moving on to night terrors. This is an abnormal sleep condition. Patients will have a normal sense of fear. They'll be kicking and thrashing in their sleep, and they won't have any memory of it. This can last about 20 minutes. They can return to sleep as nothing happened, or they can wake up extremely confused. This is more common in kids. Kids usually will outgrow it. So adults, if it persists, so 2.2% of adults, it will persist past adolescence. So adults usually have it past history, and it's usually due to some past trauma or other mental disorders. And then only 4% of parasomnias persist past adolescence, and then 2.2% of adults experience night terrors. Some symptoms of night terrors, so kicking, thrashing, sweating, having a frightened look on your face, and just not having any memory. Also, people with night terrors tend to sleepwalk as well. And then going over the differences between night terrors and nightmares. So night terrors occur in the slow wave phase before the REM stage. That's why you don't have a dream associated with it, whereas in nightmares you will, because it occurs in that REM stage. So that's why night terrors, they don't remember, recall the sense of terror that they got. And then here's a visual of where night terrors and nightmares occur throughout the cycle. And then comparing the symptoms between these two. Nightmares, you can orient yourself upon walking, but with night terrors, you'll wake up really confused and just not remembering the episode at all. You'll have a less intense fear with nightmares compared to night terrors. And then you cannot move during your nightmare, but you can move during night terrors, so that's why you'll see sleepwalking. Going over the treatment options, CBT again is first line, and then common medications they use is imipramine, amitriptyline, clonazepam, and paroxetine. These are all last resort and are all off-label uses. So some clinical pearls on each of these medications. You have imipramine. So some studies found that when it was administered for 8 weeks, it eliminated the disorder completely. And then amitriptyline is in the TCA, so it's a tricyclic antidepressant. It's in the same family as imipramine, but it has more side effects and is more sedating. out of all in its class. And then clonazepam needs to be tapered. There have been rare reports that led to catatonia. This is just a movement disorder. And then paroxetine, common adverse effects are weight gain and constipation. Moving on to nightmare disorder. This is repeated nightmares that threaten your survival, your security, or your physical integrity, and it impairs your daily life through social, occupational, or educational. You can have a negative impact on your family or caregiver. And then prevalence for this is 6% of adults have weekly nightmares compared to 20% of children. PTSD is the most common cause. Treatment outline for this, CBT again is first line. Currently there's only one medication called prazosin for this. There's just very limited information and evidence, and it's only done in, the studies I looked at only had PTSD patients. So prazosin is thought to work by blocking these alpha-1 receptors in the brain. Alpha-1 receptors make this hormone called norepinephrine. Norepinephrine will create this stress response, and this disrupts REM sleep, so this is where your dreams happen again. But disrupting that can lead to nightmares, is what it's thought to believe. It's not really well understood yet. And then you can have first dose syncope, so this is fainting. So like you'll faint in the first 30 to 90 minutes after the first dose. You can have orthostatic hypotension, so this is when you stand up too quickly and feel really dizzy from like a sitting position. And then a couple studies they found it was significantly better than placebo. The biggest study I found was only 59 veterans, so it is very limited information currently on how effective this is. Here are my resources. Thanks. Do you guys have any questions for me?
Questions? All right. Well, thank you very much. Good job.
Thanks.